Thank you, sir.
But it's just here for support and questions.
That's just.
Today is July 25th. The time is 5:39, and this workshop meeting of the Socorro Board of Trustees will come to order. While we don't have a quorum, this is an information session only. There are no actions to be taken, so we will proceed. I did say both the date and time, correct? Let's continue with the Pledge of Allegiance. Please join me in the pledge. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Continue to public comment. This being a workshop, it was limited only to the agenda items. There were no speakers signed up, so we'll continue with the workshop itself. Item 4A, health and pharmacy benefits.
Yes, I'm just going to do an introduction, and we're going to have Mario Carmona to do the presentation.
Thank you.
This is from the HR department, and this workshop was presented before, not a long time ago. We did some updates still, but the main purpose of presenting again this workshop is because we got new board members, and welcome. So you all have direct opportunity from us to learn about what Socorro ISD currently have in terms of insurance, health, and pharmacy benefits. After that, Mario will continue as requested with a short presentation on the insurance from TRS. And also we have Randy, your consultant is the board consultant, and also all related with insurances. He made the research, he works on research and find what is the most benefit for the district to recommend the board in terms of changes or adding or deleting or voting, but that's not the case today. But he's here just for if you need to ask him also questions. But mainly the presentation is going to be made by Mr. Carmona. Thank you.
Dr. Gonzalez.
Thank you, Dr. Gonzalez. Board President, Mr. Nájera, Dr. Carmen, members of the board. Mario Carmona, Director of Human Resources over Employee Benefits and Risk Management. As explained by Dr. Gonzalez, today's presentation is merely information. It's a workshop. And along with me is Mr. Randy McGraw, who is part of Hub International, who is the business partner regarding insurance consulting. And as briefly explained by Dr. Gonzalez, Hub International, Randy does provide consultation services in terms of our health plan, the health fund, and so on. So to start the presentation, for some of you, this information might look familiar because, as Dr. Gonzalez mentioned, this is information that was generally speaking previously presented. We did make some updates with some pertaining information. But before we get started, let me go over a quick overview of the items that we're going to be covering today. Basic terms, health plan options, design offerings, health plan rates, administrative objectives, additional access to care, district minimum contribution, health fund status, and TRS ActiveCare health plan options. Now, briefly, so that we follow along with some of the information that's going to be presented, I'm going to cover some basic terms, and if there's any questions at any given point, please feel free to stop me so I can elaborate on anything that may not make sense up to that point. A premium is what we pay to be able to be a participant in a health plan. A deductible is the out-of-pocket amount that I need to consume as the patient or as the consumer to be able to have my plan kick in and pay a percentage. A copay, it's a set fee per service, if you will. The copay, every time that we, let's say we go see a primary care physician, we have a copay. So that set fee is, it's for that. It's for to be seen and after to receive medical treatment. Coinsurance is the percentage that is not covered by the plan that I elect as a participant, and the maximum out-of-pocket typically is the maximum amount that I will expense as a consumer for my plan to kick in at 100%. Here at Socorro ISD, in terms of brief history, we have gone through some changes, nothing significant, if you will. Some of you might recall that administration has been previously tasked with coming back with different plan designs, different scenarios in terms of if we were to apply different changes to eliminate our current deficit, how would that look like? And fortunately or unfortunately, most of those changes, most of those recommendations have not been approved, other than a slight increase in copayment, a slight increase in out-of-pocket maximum, and so on and so forth. Our current plans include what you see on the slide. And if I'm not mistaken, all of you should also have a hard copy in case the information on the screen is not clear. But when it comes to what we're currently offering, last plan year, we were tasked with not only keeping current rates, but also decreasing rates and include additional options to where me as a consumer, me as a patient, or the participant can benefit from. So you'll see that every plan, and we can visit the Premier plan to further explain, has, under the traditional PPO, the option of selecting the PPO plan or the plan that includes the ACO. Just to further explain, PPO is just an abbreviation for Preferred Provider Organization. It's a specific network under Aetna. And ACO, it's a reduced network, if you will, a reduced network of healthcare providers that is abbreviated or abbreviates Accountable Care Organization. In comparison between what we had prior to 2023, you'll see that when it comes to premiums, there's not a significant change other than a reduction. As a result, or right before 2023, I should say, the plan 2023, administration once again was tasked with making the necessary steps to be able to come back and make some recommendations. Administration was taking the task on looking for ways to reduce a deficit by $4 million, conduct an RFP, extend the out-of-pocket amounts from the 21-22 medical plan throughout the end of 2022. What does that mean? Our plan previously would run from July 1st through June 30th. So that means that our plan last year would have ended on June 30th. But administration, the board approved for us, for administration to extend that plan through the end of December 31st, 2022, and not reset out-of-pocket maximums and or deductibles. So this was with notion that that would entail additional expenses to the health fund. As a result, our plan changed from a 1/1 through a December 31 plan year. As I mentioned, there was no changes to include the contribution made by the school district remain at $575 per employee per month. And at the end, the last two bullets, PPO provider network and ACO provider network, it's essentially what I explained earlier today, though the PPO network did include an additional benefit that was not offered previously with our previous carrier, and that was a network, healthcare provider network in Mexico. So when an employee or a covered dependent was to receive medical treatment by a healthcare provider within the Sinergia Médica network, it would be covered at 100%. In addition, we were to find ways to provide additional resources or services to our population. And as you are most likely already familiar, that was when the Employee Health Clinic was implemented. The Employee Health Clinic does provide primary care, urgent care, preventive health care for well woman exams, physicals, minor injuries, generic prescription drugs at a zero copay. They also have delivery service, vaccinations, on-site testing, and rapid lab tests. So as long as the service is provided and it's available at the clinic, the only out-of-pocket expense for an employee or a covered dependent is $10. It's the approach of a holistic approach, if you will, a one-stop shop. You walk in, you are assessed, and if during the assessment is considered that you need a prescription and it's available in generic form, they'll make it available to you. Going back to the contributions made, I'm going to be making a separation on what is a district minimum contribution and what is currently being contributed by Socorro ISD. So first, let's go over the district minimum contribution. At a minimum, a school district must contribute $225. That is $75 from the state and $150 from the school district. The total minimum district annual contribution is $2,700 per employee per year. For an average monthly enrollment of 5,200 employees, the minimum district annual contribution would total $14 million. Now on to the school district contribution. Socorro ISD makes an additional generous contribution of $350. That would total, as I mentioned, $575 per employee per month. That total is an annual contribution of $6,900 per employee per year. For an average of 5,200 employees, that will total to a little bit over $35 million. And then we also like to make a comparison in between the two amounts that are being contributed. The minimum required, as I mentioned, would total to $14 million. The SISD contribution will be $35 million, a little bit over $35 million. So the comparison between the two, there's a difference of $21.8 million. You'll see a table right next to that amount, and that's to illustrate, well, you see the highlighted amount. That's the amount that at that point, during that plan year, was a deficit. So that will be the amount that was transferred from the general fund over to the health fund. Next, you'll see the same type of comparison, but for plan year 2021 versus 2020. And thankfully, with some of the changes that we were approved to move forward with, you will see that in 2020, the transfer amount was $9 million. And thankfully, we began to see some changes in the direction to where we were heading towards eliminating our deficit. And we went down to 4.5. So in terms of the deficit, you'll see that just for some historical data, in 2018, $9 million were transferred. 2019, $9 million. 2020, $9 million. 2021, 4.5. 2022, $4 million. And in respect to what is it that we're expecting to see in the future based on the current changes, the change of the plan year and so on, we are proposing a budget for the health fund of $64 million. What does that budget include? It includes $45 million for medical claims, $14 million for prescription claims, and then administrative services for continuation of coverage, COBRA, for administrative fees such as Aetna, consulting fees such as Hub International, the Affordable Care Act fees, and the Employee Assistance Program. So that will total to the $64.7 million. So in essence, that's how much we're anticipating that it will cost for the plan year through the end of 2023. Now, why is this important? Why is it important for us to continue going back to the deficit? The deficit, it is because we are self-funded, and as being a self-funded plan, we hope to be able to have enough funding to be self-sufficient. And that's one thing that we're not right now. We, as you can see, have been running for the past few fiscal years in a deficit. So when administration comes before you and we make some recommendations, it's an effort to be able to eliminate that deficit as much as possible. Now, in addition to providing with some historical data, we were also asked by administration to bring forth some information regarding TRS ActiveCare. And bear with me, this might be as new to you as it is to me, but I'm gonna do my best effort to go over this information. When you hear TRS ActiveCare, this is essentially the same principle when it comes to a health insurance. It does have a co-payments, it does have deductibles, it does have out-of-pocket maximums, a network of providers. Essentially, it works just like what we have right now. The difference is going to be on what is paid by the employee or the participant and what is paid by the plan. So even though it works just like any other medical insurance, benefits are different. What do I mean by that? If I'm not mistaken, you should be able to see better than I can the slide. But in your slide, you'll be able to see that if the district was to offer something comparable, and let me move to the next slide, I think it's a little bit better. It's 2 slides after that, where we're comparing the base plan versus TRS ActiveCare Primary Plus. So here, you will be able to see that when the 2 plans are compared, we will be able to provide essentially a comparable medical plan at no premium to the employee, at no cost to the employee. In addition to that, it does include in-network and out-of-network benefits. It does have a deductible, co-payments, and co-insurance, and a maximum out-of-pocket, In addition to that, just like any other plan, it covers your annual exam at 100%. It does cover any other preventive care services, just like our current plan does, our flu shot, our COVID vaccine. But the major difference will be the following. Apologize, let me get to that slide. Okay. So SISD could contribute an additional $230 to the $225 minimum required contribution. That would mean that the contribution for Socorro ISD would be $455 per employee per month. This would mean that for someone who enrolls in the TRS ActiveCare Primary Plus for employee only, the cost would be $455, which I mentioned will be covered at 100% by the school district if that was to be the amount adopted as a contribution. The total annual contribution could be $5,460 per employee per year. versus the current $6,900 per employee per year. For an average monthly enrollment of 5,200 employees, the annual district contribution amount could total $28.3 million versus the current $35.8 million, a difference of $7.5 million. And I want to make sure that we're following on the same slide. Yes? Okay. Now, you may want to know what is our current enrollment. And why is this important? Because if in the event that a change was to be made, this is the number of people that could potentially be impacted by any change in or implementation. But the current enrollment count for the Premier Plan is 1,560 under PPO, 55 under ACO. For the base plan, PPO 3,375, ACO 126, and consumer-driven health plan, PPO 104, ACO 69. So how would this look versus what we visited earlier regarding the budget impact or recommendation? TRS ActiveCare Primary Plus for employee only, as I mentioned, would be 455. If we were to look at the revised budget versus TRS ActiveCare, we are assuming that there will be a difference of $36.2 million. Questions so far?
I have a question, Mr. Carmona.
Yes, Mr. Nakara.
Looking at the cost on the TRS ActiveCare, I noticed there are no numbers for pharmacy, COBRA, or admin fees. I mean, those, especially pharmacy and COBRA, those aren't going to go away. So where are those fees?
That will be a fee that will be already included in the fees that are paid to TRS. There's no separate fee for that.
So regardless of how many prescription claims, our prescription claims could double, triple, quadruple, and that 14,000 is already embedded in that 14 million is already embedded in that 28 million fee.
That is correct. Keeping in mind that just like our plan, TRS does have a formulary as well. So there is prescriptions that are included. There are some that are excluded to include specialty pharmacy. So it has, again, same principle. So generally speaking, that is correct. But again, I would not say that everything is covered.
Okay, and then what portion of that $28 million is actually their fee? Because, I mean, right now, when we look at the revised budget for 2023 and we look at health, we know that that $45 million is what we anticipate our medical claims to be. That is our responsibility, incorporating all the discounts that we have with our current TPA and the network that they provide. I mean, we truly are paying out $45 million in claims. So of that $28 million over in TRS, what portion of that is claims and what portion of that is actually their fee?
That's a good question. I don't have that breakdown for you, but we can bring that information over. Yes?
Like Mr. Randy does.
Good afternoon, Board President, Dr. Carmen, members of the board. I'm Randy McGraw with Hub International. So the difference between TRS and Socorro ISD is that, excuse me, TRS is a pool of about 1,000 school districts. So all their claims come together inside of TRS, and then TRS bills the districts as if it's a fully insured contract. So in a fully insured premium, all of the line items that you see here are embedded inside of the premium. So then the obvious question is, how can TRS do this for so much less? And the answer is, they are the beneficiary of a lot of largesse from the state. So this year, in the budget session, the governor allocated $500 million that he gave to TRS to help keep premiums low, so a subsidy. And then last year, he also gave another $500 million to TRS. So $1 billion in the span of 2 years from the state to TRS to subsidize the cost of health insurance. Yet, as we're all painfully aware, in this budget cycle, there's no new money for any other school district. So everybody inside of TRS received this subsidy. But the premium that you see on these rates or the other ones encompasses pharmacy, administrative fees, prescription drug. Prescription drug under TRS is administered by CVS, which is the same pharmacy benefit manager the district uses here.
McGraw, don't go nowhere, sir, please. I do have more questions, but, and maybe, I believe they might be for you. So, is there a reconciliation at the end of the year? Let's say that, you know, I'm assuming that TRS arrives at what our fee is based on our claims history, but
No.
no, so no reconciliation. That is our responsibility, and that's it.
Yeah,
Even
so-
if we have all of a sudden, you know, 20 catastrophic cases next year that account for millions of dollars each case by themselves. Let's say those, and let's make it easy, right? Let's say that we get 28 catastrophic cases. We hope that's not the case, but I'm just trying to understand the fee. At $1 million each, so those catastrophic cases themselves total exactly the $28 million they're charging us. That's still our only responsibility, that $28 million?
Correct. So TRS treats the member school districts as if you're under a fully insured contract. And so fully insured means you have a premium, like most small businesses or medium-sized businesses have, and you pay the money to them and the carrier assumes the risk. So TRS as a collective pool assumes the risk in the entire population. And they don't know who's going to join their pool or who's going to leave their pool. Up until last year, there was a legislative rule that once you're in TRS, you can never leave, kind of like the Hotel California.
Right.
But they changed the rules a couple of years ago, actually because of actions taken by El Paso ISD under our guidance, where we created an alternate plan and kind of train wrecked the rules. So TRS changed the rules now. So if you are in TRS, you can say, I want to get out, and you can leave now, but you have to stay out for a minimum of 5 years. And on the flip side, if you're outside of TRS and you want to join it, there's not even a contract to sign. You write a letter to TRS and say, I would like to be in TRS, and they say, welcome, and then they enroll you. They don't ask you for any information. They just admit you. And then they bill out the premiums to everybody as if it's a fully insured contract. And another result of the changes in legislation, and there's a separate handout I believe Mario gave you. This is about as good as it gets on the TRS website. It's a 4-page document, and you can see that it's labeled Region 19. So one of our gripes with TRS historically was everybody in the state paid the same rate, which we cried foul at EPISD because the cost of healthcare in El Paso is a lot cheaper than it is in Houston. And we felt it was unfair for us to subsidize Houston. They're not subsidizing us. So part of the changes in the reform is each regional service center now has everybody has the same benefit, but by region, the rates vary to reflect the cost of delivering healthcare in your region. So anybody in Region 19 could write a letter to TRS and sign up, and they would get exactly the same rates and benefits as everybody else in Region 19.
The question that I have, and I think that's why we're discussing it today, and please correct me if I'm wrong, is that the numbers are here and it shows how we could save money if the program or if the plans were apples to apples. My understanding is that they are not. Even from Cigna to, I think right now is Aetna,
Right.
to TRS, my understanding is that there's certain doctors that are excluded, medical providers excluded, pharmaceuticals that are excluded. So how can we get a good apples to apples view to truly see if what we're saving or not truly impacts, or how it impacts our employees.
So you actually could go back to last year when we did the RFP process here, and we had proposals from Blue Cross and Blue Shield, and Blue Cross administers the medical portion of TRS, and CVS administers the pharmacy benefit manager portion. And so TRS is, you can call TRS, they don't even give you reporting or anything. You just, if you join TRS, there's only one decision the district has to make each year, and that is, how much do we want to contribute? You don't get to change the plans. If there's a claim that needs an exception, you can't override the claims administrator. So whatever TRS says goes, and they'll tell you what the benefits are, and you can't say, well, I would like to have a different deductible. So theirs would be exactly the same. But we do have a good network comparison of Aetna versus Cigna versus Blue Cross Blue Shield, where we took all of the providers that treated your members in 2021 and matched them against each other on a line item basis. And the number of, or the physicians in network between those three are very, very close to each other. On the pharmacy side of the equation, then it can be different. Even though it's CVS at TRS and CVS here, there are different lists of preferred drugs that CVS has to offer. And so we're not, believe it or not, we're not in their most aggressive list, which you would think after the transition for people that were disrupted and said, I used to get this drug at this copay and now it's at that one. So those things happen when you change from one PBM to the other. But the pharmacy formulary list under TRS is going to be more strict than the one here at Socorro. So earlier this year, one of the things we changed was we put a $5 copay on generic drugs, but generic drugs were still dispensed through your on-site clinic at no cost. But some employees complained, and the board came back in end of February and said, let's just make it go back to a $0 copay. So we were able to do that because we instructed CVS and Aetna, as of this date, go back and change everything, make it a $0 copay, and they did that. You can't do that at TRS. TRS will say, this is the deal we have, you're just along for the ride, all you make a decision on is how much you're going to contribute. So their rates are obviously very competitive for what they have to offer. And then there's also, I think, one other important difference. Where's the one that has the TRS? The one with the grid. Down this way? Nope. This slide. So even though the plan design, and Mario showed you a comparison of our base plan, which has a $1,250 deductible, against the primary plus plan, which has the same deductible. But their out-of-pocket maximums and some other things are going to vary. And we could match TRS, but TRS can't match us because we can change our plan. They're stuck with what they have. It's important to note, too, on the right-hand side of this slide, that the provider networks for the primary and primary plus plans under TRS are HMO provider networks. And so you can see there on the note that that's different. And employees would have to select a primary care physician, and that's their first point of contact. And for specialty care, so I've got a heart condition, my primary care doctor would have to say, you need to go see El Paso Cardiology, and I'm going to give you a referral. And then I can go to El Paso Cardiology, and then they can start treating my health condition. As opposed to your PPO plan design you have right now, I wake up, check my blood pressure, say, I think I need to see a cardiologist, I can just go straight there. So you have this gatekeeper arrangement between the primary care and the specialists. And also HMOs only work inside the geographic territory that they are in. And so Blue Cross of Texas only operates in Texas. And so there's no coverage under the primary or primary plus plans if you go out of state. And there's also no out-of-network benefit. So in other words, if my doctor wasn't in the HMO list and I go to see him, I get no benefit. Under the PPO plans we have here at the district, if my doctor's not in the network and I go to see him, it's still covered. I just have a higher copay or deductible or things like that. So it's a little more restrictive in terms of that. And so then that also begs the question too, so how does that impact your employees? Most people seek all their care here inside of Texas, but your dependent kids may be going off to school somewhere else. And so if you were in the HMO network and you're going to school in Phoenix, you're covered for emergency care, but not to go see a primary care doctor or to go into a hospital for a procedure, things like that. They offer also through TRS a consumer-driven health plan, same concept as we have here at the district. And their consumer-driven health plan is offered on a PPO network. So the consumer-driven health plan through TRS would be able to accommodate people outside of the state of Texas, as well as non-network providers inside the state. So those are some key differences. There's no doubt their costs are very low, but you also want to be aware of some of the restrictions on the benefit side.
Thank you.
Sure.
So I believe we're almost at the end of the presentation. If I'm not mistaken, this is the last slide. So currently, I'm sorry, did I? Thank you, Dr. Carmen. Yes, I did. TRS ActiveCare, the proposal, one of the major differences is to possible higher out-of-pocket in the board, if the board elects to go to TRS ActiveCare. SISD could save up to an annual of $1 million to offset the $2,300 in out-of-pocket expenses for employees who qualify with medical needs. SISD could serve over 400 employees with this annual fund and still save the district over $28 million. Currently, the number of employees who meet the maximum out-of-pocket, and we do have that information available if you need those numbers. We have printouts available so you can see how many employees actually met that maximum out-of-pocket. And Dr. Carmen, you were on the right track, around 400. An employee who elects to participate in TRS ActiveCare primary, their premium will be $388, or ActiveCare high deductible $403. SISD would contribute the difference from the $455 per employee per month district contribution into a health reimbursement account, or HRA, or a health savings account, HSA, for them, respectively. That would translate to employees receiving, if enrolled in an HRA, a contribution of $67 per employee per month, to total an annual contribution of $804. And if a health savings account contribution of $52 per employee per month, to total an amount of $624.
Mr. Carmona, could I ask you to go back 2 slides?
Sure.
I just want to elaborate on your point there. On this slide right here, that last bullet, I think the numbers changed on the previous slide to where the savings would be $36 million. So if the district chose to put aside a fund of $1 million, the savings would still be over $35 million. And the reason we came up with that $1 million estimate, the difference between the maximum out-of-pocket of $4,600 on our current base plan increases in the Primary Plus plan with ActiveCare to $6,900, so $2,300. And so to offset, that's one of the bigger concerns with TRS, other than the network selection, no out-of-network. So to offset that cost to our employees, $1 million would take care of that. Similarly, in discussions, it's not on this slide, but if the board chose to go with TRS at some point in the future, a similar fund could be set up to offset pharmaceuticals, for example, that are not in the formulary. There could be guidelines that would qualify employees so they wouldn't be adversely affected. And again, we're starting off with a $36 million difference there in savings. We could choose as a district to set up these funds separately and to administer them to offset some of these costs so that our employees are not negatively impacted financially. should they choose the HMO, we can't do anything about the lack of out-of-network, but we can do something with these savings to offset their costs. That was it. Thank you, sir.
Thank you, Dr. Carmen.
So just to clarify, administration is recommending for us to look at TRS ActiveCare?
Yes, ma'am. I think we should investigate it, compare it to what we have currently, our previous plan. There's going to be concerns with health insurance, regardless of whom we go with, whom we select. From a financial perspective, because of the state supplementing, offsetting a lot of the costs, as Randy explained, this could put the district in a much better financial situation. And again, with those savings, we can set up funds to offset the cost to our employees. Again, we can't do anything about the out-of-network, but we can use this money to benefit the cost to our employees if a change was made.
It's not necessarily a question. I just think that if it's something that we as a leadership team we're going to consider this, that it not be done with just our feedback. I think that our community, our teachers, our educators need to be aware that this may be in the works so that they can do their research and say, well, okay, but this is really going to affect my family because my family's physician has a special situation and they're out of network, and this is my personal impact. And I know that we're taking it out and making it much bigger, but I think it's really important. I think our district was negatively affected with our last changes regarding healthcare, and I don't think that it's fair to them that we blindside them again and say, oh, by the way, this is what's going to happen now. I think that they definitely need to be included, whether it's in community meetings, it's meetings with our teachers. I mean, not necessarily the community, but our teachers definitely need to be a part of this decision.
I think that's a great idea, and I think a health insurance committee that's representative of all of our campuses and our departments would be a great next step for us to begin to investigate and then come back to the board at a later date with their input, in addition to any questions the board might have between now and then. I think it's a great idea.
And I think I agree with Ms. Macias. It's not, it seems, sometimes things seem too good to be true, and I think that, great, it's going to help our district, but I want to make sure that the changes that we make are in the best interest of our teachers and our employees and our staff. I'm all about saving money and getting us out of the red, but not at the cost of people.
Mr. Carmona, I'm sorry, you done, Mr. Carmona, so, I mean, I know, I heard you say somewhere along the way that the impact with out-of-network physicians was minimal, but that was not the experience. And I don't know if it's just disproportionate, that those who were impacted, made the most noise, right? And that may be the case. You take my physician away that I've been going to for several years, and yeah, that is going to impact me, pretty significantly. But if we do have, I would be interested in seeing, it sounded like you had that information, which, and if we could go back, to where, which physicians were in network last year that weren't in network this year, which is one impact, and which physicians are in our network right now that would not be in TRS, because now we're facing the probability that we're going to impact someone 2 consecutive years if their physician is not, in there. The same thing for the formulary, because, I know that the copay, was an impact, but the non-covered drugs was even more significant, and I certainly understand the impact there, because to go from, a $5 copay to a $40 copay for a formulary drug, that's significant, but to go from $5 to non-covered and all of a sudden, the pharmacy hands you your cost and it's $800, I mean, that...
In the thousands.
There you go, I was being generous, but, And I know I've encountered those situations. You know, I do not, neither me or my spouse have district insurance, but you know, we've struggled through that, and we're in a situation where the medication is needed. So, you know, whether it's $80, $800, or $1,500, you know, we unfortunately have to pay the fee and then try and figure it out on the back end, which is extremely painful. You know, luckily, we're able to navigate through that process, but I mean, $1,500 on, you know, monthly expenses is significant, right? So I want to understand those differences and make sure that when we say that disruption will be minimal, it's not just an abstract number, that we know exactly what the disruption is going to be, that it's not a specialist, you know, where there's one specialist in El Paso, and we have an employee who is receiving, you know, care for my mind right now, but a condition that's not going to go away. You know, it's being managed.
Right.
Right. That we're not going to, that physician is not going to be, you know, all of a sudden out of network, and therefore they no longer will have a provider for their specific illness. What happens to our health clinic? I mean, if TRS is the option, right now we've got 0 copays for the health clinic. We also have a provider there, but I anticipate that neither one of those is part of the TRS care network.
You are correct. The clinic does not operate under any network for that matter, since it's part of the health fund. It's subsidized through the fund. Just to make sure that I wrote down the first question correctly, you would like to see the potential disruption network when it comes to providers and formulary for prescriptions, right?
Right, and only if it is, you know, if, just to make it simple on me, right? If I'm not taking Excedrin migraine today, and I know that's over the counter, but just if I'm not taking Excedrin migraine today and it's not on the formulary, you know, for next year, well, it doesn't matter because I'm not using it now. I want to know from the pharmacy, from the prescriptions that are current, what will be not covered.
Got it.
Okay.
We can definitely work on that. And then to your second question in respect to the clinic, just like Dr. Carmen mentioned.
Same thing for the providers.
Yes.
But I do want to go back for the providers. I do want to, you know, and I want to understand, you know, last year to this year and this year to next year.
Absolutely, yes.
Okay, thank you, sir.
No problem. In regard to the clinic, just like Dr. Carmen mentioned, there will have to be a conversation regarding how that will be funded, because that is something that's coming directly or is being directly funded from the health fund. So being self-funded and having the ability to dispose of that funding as the board and the school district administration feels as necessary, the clinic was implemented. It's part of the benefits. So if we were to go to TRS does not fund the clinic. That will be something that will need to be spoken about separately.
I want to understand then what the costs are for the clinic, because then we have two options, right? We can back out the costs from this year's plan, because if we didn't have the clinic, we wouldn't, you know, have those costs. And I understand then that it was supposed to be an offset, and if we weren't doing it at the clinic, you know, but the potential is that we keep the clinic and we're going to have to absorb those costs anyways. So what proportion, what is the dollar amount of the cost that we would be absorbing? Because I don't think it's a good idea to have invested all this time, energy, you know, the promotion of the clinic, and then all of a sudden do away with it. But I want to understand what is, you know, the impact, what is the cost to maintain that clinic, even if we went to TRS. I also believe that a more accurate comparison would be our base plan to the ActiveCare primary, because if you look at it, we have a base plan, we have a premier plan, and a consumer-driven plan. And when we look at our documents, the premier plan is first, even though it's a better plan. base plan is right in the center, and then the consumer-driven plan is higher cost, you know, to out-of-pocket cost to the employee, right? And when we look at the layout of the TRS plan, their base plan is all the way to the left. Their primary plus plan, which appears to compare to the premium plan, is in the center, and then they've got the high deductible plan. So I don't know which, I mean, I guess we move ours, but we also make the comparison of, you know, apples to apples, their ActiveCare primary to our base plan. And I think, I mean, there's a lot of information because that I think we need to study, because if you look at the plan, the employee-only cost of our base plan, it is $53. Theirs is $0, right? But then you go to employee and spouse, it's $299 on ours. ActiveCare is $593. Employee and children on ours is $198. ActiveCare is, or TRS is $198. When you look at employee and family, our cost is $477. TRS is $865. So there's some significant, you know, increases, yeah, in premiums there, and that doesn't, you know, as we look at even pharmaceutical co-pays, et cetera, their co-pays are pretty significant as well. And I certainly understand, you know, I understand what we're trying to do here is we're trying to manage constantly increasing, sometimes even exponentially, costs in our health coverage, but I want to understand those, because right now what I see quickly is, well, let's just shift that cost, because that's what it looks like. I mean, when I'm looking at the base plan at $477 for employee and family, and I'm looking at TRS ActiveCare at $865, that's almost doubling the employee contribution. So, you know, let's look at, or, you know, to look at exactly how much we would be saving, right? I would just do a quick calculation, you know, take our deductible minus, our premium minus their premium, and look at how many employees we have on that plan, and is the difference there going to be $1 million? So yeah, we're saving $1 million, but we're passing that $1 million over to the employee, which, you know, I mean, that might be the choice, right? But it's also not fair. Yeah, it's cruel.
Absolutely, we can make that comparison side by side. And another item to point out, Mr. Nájera, is the percentage, the core insurance percentage. One of the reasons why we compared the base plan to TRS ActiveCare Primary Plus is because the co-insurance is 20%, which is a percentage that's relatively the same as base. The primary is 30%. So there's some items that will not necessarily compare apples to apples, but we can definitely add that information. Randy?
I'm Randy again. I was going to start by looking over my shoulder because the last time when I was here in the fall, I made a proposal to you that you should raise the cost of your spousal coverage, and I could feel the knives and arrows in my back then. And so, you know, that was a large part of the discussion last year, and we had several passes by the board to mediate that. And my comments then were, it's okay to subsidize it, but you should call it what it is. And so we ended up with the same rates that you have. But in the world of TRS, there's 4 different tiers of coverage, just like you have here. And they load the different tiers according to the risk, which is what I was proposing last year. And so even though in TRS hits the categories with spouses harder than they do with children, as you can see on the rate, which was kind of what I was proposing last year too. So the way to handle that is, right now the district contributes its $575, and subtracts that from the total amount to get to the payroll deduction. And so in the grid that you're seeing in the presentation, Mario took the $455, the revised contribution, and applied it equally across the board. But there's TRS, as long as you contribute at least $225 per person, they don't care what you do in the other categories. So one way to handle that would be to say, we're going to pay $455 if you have single coverage, and we're going to subsidize the spouse and the family rate higher to bring that payroll deduction down, more in line with whatever your preference is as the board, looking out for your constituents, the teachers and employees of the district. So there's different ways to handle each one of those categories, and you guys have done a great job of hearing a lot of information in a short amount of time. So there's that variable that you have control over, and that's really the only one. How much are we going to contribute? Because the benefits will be determined by the state, and that's what will be there. One other important thing to understand is that TRS cycles September through August. So just like Mario explained at the district, we used to cycle it July through June, your fiscal year. TRS is old in their ways. Way back when they came into being, the fiscal year for school districts was September through August. So their deductibles and out-of-pocket maximums reset every September the 1st. You can join TRS anytime during the year. It doesn't have to be on January 1, which is your anniversary date. It doesn't have to be on September the 1st, which is their anniversary date. You can do it whenever you want. You just need to be aware that, let's say, for example, you changed on January the 1st. So your employees, their deductibles and everything would reset on January the 1st. You join TRS on January 1st. You start all over with them, just like you would with you, with the difference being on September the 1st, it resets again, so it would be a short year. So, and then on the flip side of that is, if you joined in on a September the 1st date, then you're shortening your current plan year, and you're starting it over before it hits the 12 months. So those are some of the little nuances that come into play when you're either joining TRS or leaving TRS, is the timing of things. And all of those can be handled, but it would take a little more time than this workshop allows. But those are some of the key things to be aware of.
Thank you, Mr. Bra. Mr. Carmona, what's our timeline? I mean, assuming that if we do go for RFP, we get proposals, we evaluate them, whatever, then we have to choose one, right? And then we need to allow for the enrollment period, and then the new coverage begins January 1. So when would we have to have a decision? Which board meeting? Because I know it's not December. Because
No,
that would
absolutely not. No,
Right.
To your point, you are correct. There is a timeline that we need to follow. One month that we like to point out is the month of October, which is the month when we conduct annual enrollment. So I would say probably no later than next month will be a month that we will already have to have something scheduled to evaluate if we were to be making any changes effective 1/1.
So you mean we would have to do all evaluations in August and then make a determination in September?
Go ahead.
So for TRS won't respond to a RFP. For TRS, you get their handout, you write them a letter, and you're in. The RFP would be to solicit proposals from people outside of TRS, which is what we did last year.
Right.
And last year, we kicked off the RFP process in the end of May, I believe it was, and we were here in August. So it's about, if you do an RFP, it's about a 4-month start to finish process. But to join TRS, you would not need to do an RFP. They're not going to even write you a letter.
Yeah, I'm just not sure that TRS is the right option. So I want to be sure that we allow enough runway to explore the options. Because, there's more than just, I want to understand TRS. Not every single school district is on TRS, and there's got to be a reason why.
Right.
If it was great, then we wouldn't have 1,000 districts. We'd have every single district in Texas. And we also have offsetting considerations as well. Like I said, the clinic, we've invested so much in trying to facilitate the delivery of care to our employees, and to just do away with that, there's opportunity cost as well. And so, I'm what I'm thinking, and I mean, we can't make a decision right here, right now, but my thinking, my opinion is that we get quickly started on the RFP process, or maybe just for information, right? Maybe we just look at what our premiums are, and whatever, maybe we have to make an adjustment, unfortunately. I mean, we maybe got a little too aggressive last time, but maybe we got to strike a balance this time, because regardless, we can't stay on the path that we're on, because it is unsustainable. So I just want to make sure that we're able to pursue all options so that we have options. I don't want TRS to be the only option. I mean, because I guess if TRS is the option, right, we can just write them the letter.
Right.
Right? We don't need the RFP.
Sure.
The other thing, Mr. Carmona, I'm sorry, I can't see either the slide or the information on the TRS. I'm having to,
It's very hard, yeah.
yeah, do like the menu when I forget my glasses at the restaurants and put my phone on it and make the
Yeah.
camera bigger.
Yeah.
So is there a link? I mean, are these, or I mean, is it possible to get something,
Yes.
a little clearer? Because
Yes.
I really am having a hard time.
Absolutely, yes, and I apologize for that. In order to condense the information and make it available as one piece, we presented it as such, but yes, we can.
Okay.
Absolutely.
And I think if TRS becomes the route that we're going to take, the fact that our clinic could possibly go away, I think that's important information for our staff as well. Because there's a lot of people that rely on the care that they do receive there, and we need to find out, well, how will this impact you? And I don't want to make a decision because it's hurry up, we got to do this now. I think we need to make decisions based on what's best for our teachers, and that's our job. So I'm with you, Michael. I think we need to explore a little bit more.
Any other questions? Mr. Carmona, Mr. McGraw, was there anything else that you wanted to add, sir? You look ready to. Yes, sir.
At the risk of delaying your meeting a little longer, I do RFPs for a living, and I do them here in El Paso too. So I did take a look at last year's results, and when we compared the networks between Cigna, Aetna, and Blue Cross and Blue Shield, the network, and it was your actual utilization. We took a year's worth of data and compiled a database so you could see them as a line item. Cigna actually had more people out of network than either Blue Cross Blue Shield or Aetna based on the same pattern of utilization. And then the other thing too is I don't have to do an RFP to know everybody's weaknesses and strengths in the marketplace. I do RFPs because you have to prove that you did your due diligence and things. So I can tell you too, and we're concluding one for El Paso ISD right now. So they're at the tail end of where you were last year on the same thing. So I'm seeing current information, and it's no different than it was last year. So you could do the RFP again, but you should not expect different results from what we already saw. The other thing too is El Paso ISD operated a clinic as well before they joined TRS. When they joined TRS in 2011, they made the decision to keep their clinic going. My advice was, there's no need to have the clinic anymore because it doesn't really matter. I mean, it matters to your employees because they can get in and see somebody and not have to wait for an appointment and things like that. But that's a pretty big price tag to pay. The role of the clinic really is to help improve the population health of your membership and to divert claims away from the health plan and do it in a more cost-effective setting in the clinic. And so in this case, if you were to operate the clinic just like El Paso ISD, and I was like, you're helping them save money, but they're making you pay for Houston and all this, it doesn't really make sense. The other thing too is if you join TRS, you don't need a consultant like me. Because all you have to do each year is just decide how much am I going to contribute. You don't need to pay me money to tell you the answer to that question. So there are some other areas that you would want to visit, like you're identifying, and determine, is that something we want to continue to do? And then make I would just say it's a conscious decision. Like, yes, we know we're going to spend $1.5 million on our clinic, but we're willing to do that to give our employees another avenue than whatever's available to whichever health plan that you have. But from a strictly math and dollar perspective, it wouldn't make sense to continue to offer the clinic. So that would be something you do because you want your employees to have it, not that it's going to save you any money on your health plan.
Is the EPISD RFP responses, are those public record?
When the board votes on it, they will be. They're destined to take it to their board in August. I think the 17th or so, whatever the third
15th.
Wednesday or Thursday is of the month.
And we still have, Mr. Carmona, the RFP responses or the comparison of the responses from the last time, right? Maybe it would be a good idea to get a refresher of those, especially since Ms. Gardea and Ms. Macias were not on the board at that time.
Absolutely, yes, that information is available.
Okay, thank you.
And something that was said, I just need clarity on, so teach me. One thing that I've heard is that it doesn't matter which provider we have, it's what the district is now paying, or it goes back to the formulary. So teach me how the formulary changed between, and maybe that's something that you could provide us between Cigna and Aetna, because I think that's what I keep hearing. It's not the fact that Cigna was the facilitator or Aetna, it's what we are now paying into or allowing them to pay. And that's why, again, the concerns or the changes in where something like insulin that had been approved for years was now not approved.
Right. So if I'm not mistaken, Ms. Macias, you're referring to the prescription formulary?
Possibly prescription, and then also, I also heard the same thing, again, just like Mr. Nájera said, with our prescribers, with the medical, who is in network, who is not, and I think that would help us identify. Because I do agree, I mean, for Aetna, what you mentioned is that there's many more individuals here in El Paso that do qualify, but I guess for some of our employees,
Yes.
it's a change for them.
And some of the paperwork, as we go from one third-party administrator, Cigna, to Aetna, although our employees who were covered had prior authorization on file for, whatever provider or whatever medications they happen to have. Once we made that change, that process needed to be started again because those prior auths don't carry over. So it was, some paperwork that had, and that's going to happen again. If we make a change to TRS or to anybody else, if we return to Cigna, if we go to Blue Cross, if we do anything other than stay with Aetna, all that documentation that's on file, all those processes, all those approvals that are in place right now, they will have to start again because nothing automatically carries over from one provider to the other.
You're absolutely correct, on the right track, especially when it comes to those treatments or medications that are prescribed for chronic illnesses, which tend to be the most expensive. And as different formularies or formulas become available, they push over different drugs to a lower tier, or they fall off the formulary because now they become available over the counter and they're no longer covered. So it depends on what item or type of service we're referring to. But since you mentioned insulin, it's a hot topic throughout the nation, whether because of supply, demand, because there is no generic or there's not enough of a certain type of medication, or because it's not being utilized correctly. I don't know if you have heard that there's a medication that's being used more so for weight management rather than for the care of the illness itself. So it's a combination of things, to include what Mr. Nájera just mentioned. From one carrier to the next, the process might be a little bit more limited in terms of they are very sticklers to the rules. So if they don't have that piece of paper from the prescriber, they will not move forward and allow for the pharmacy or the specialty pharmacy to dispense the drug. So it's a combination of things. Unfortunately, for those cases that we heard about earlier this calendar year, it was related to that lack of following certain steps, but thankfully we were able to get all that information together and assist those employees.
Thank you. And my final question, since we did start talking about the employee clinic, I know on slide 16, you showed the SISD Health Fund deficit and how in fiscal year 2021, 2022, there was a less amount of influx, again, the transfer. How much of that was due to the benefit of the employee clinic? Or was there, and again, you don't have to provide it to us now, but that way we could show the benefit of the employee clinic, that it's not just the service part of it, which is very important, but it also does have a bottom line that it does help us save money.
Absolutely.
And if not, then we know.
We can provide that information as well.
Thank you, sir.
Sure.
Questions? Okay. Well, if there is, since there is nothing else on the agenda, nothing else before the board, our meeting is adjourned. The date is July 25th, and the time is 6:50.
Thank you.
Thank you.
Thank you, Mr.